something called cardiac output. And when we look at cardiac output, there's two components we will be investigating. One is SV, which you know is stroke volume, and the second is HR, known as heart rate. In this lecture today, we are going to define cardiac output and talk about why it's so important. Then we're going to focus on stroke volume. There are three primary factors that alter or affect the stroke volume. They are the EDV, end diastolic volume or preload, contractility, and something called the ESV or afterload. So what is cardiac output? Well, cardiac output is literally the volume of blood pumped by the left ventricle in 1 minute. Now remember, the volume of blood that leaves the left ventricle is the same as the right. It's the pressures that are different. But we're going to focus on just the left ventricle because that's the most important one. So if I want to know how much blood leaves my heart in a minute, I have to know two things. I have to know how many times is it pumping per minute, my heart rate, and then I also have to know how much blood is it pumping out every time it beats. So when we look at cardiac output, we need to know our heart rate, which is easy to take, and our stroke volume, which we estimate. Kind of hard to measure a stroke volume. You would really need to do an echocardiogram. Now understand, why are we looking at cardiac output? What's the big deal? Well, the whole thing comes down to, that's an O, is that cardiac output is directly proportional. That's what this little funny symbol means. It's directly proportional to blood pressure. Now, blood pressure is critical. It's the force of blood going through our vessels, getting to all of our organs. We do not want our blood pressure to drop. We will have organ failure and shutdown. And we don't want it to be too high because then we can have thrombi and embolisms. So we know that if anything increases our cardiac output, it's going to increase our blood pressure. And we know, I'll come down here, if anything decreases our cardiac output, then it will decrease our blood pressure. And so we're going to come back to all of this next week when we look at blood pressure because it's so critical. So when we look at heart rate and stroke volume, that gives me cardiac output. Now remember, stroke volume was the amount of blood that's ejected per beat, and we said that was around usually 70. Now these are all at rest. So your cardiac output at rest is around 5 liters. So 5 liters of blood are pumped out of your left ventricle every minute. Now that can go up, right? There's times when we exercise or we need more blood to get out. And in a diseased heart, it's going to drop lower. Remember, our stroke volume was basically, if we looked at how much blood was in our heart before it contracted, the EDV, and we know that not all of it leaves. If we know how much was left behind, the difference is what has left. So here's a short little video from Interactive Physiology that I think kind of shows you cardiac output.
Cardiac output equals the heart rate times the stroke volume.
It's a pretty simple animation, but I think you get the picture. Now, two other terms to know. Ejection fraction is always a percent fraction. And what you do to calculate this is you have to have the patient's stroke volume and you divide that by, which again is usually 120, right? Their EDV. Well, again, the way to measure a stroke volume is really an echocardiogram. It's kind of hard to measure it. And so they calculate this and it's just showing you the percent of blood that leaves the heart. And it should be around 60%. Well, the lower the ejection fraction, the more diseased the heart. In fact, if it's below 40%, that's very, very low. That's clinically significant. So a patient with heart failure will have a decreasing ejection fraction. And the cardiac reserve is just our reserve. Remember, these numbers I gave you were at rest. So we always have a reserve. Sometimes we need to get more blood out of our heart if our fight or flight activates or we exercise. So that's just taking what your max cardiac output is and subtracting your resting. So what's a max cardiac output? Really highly trained athletes, it can be 25 to 30 liters per minute, right? At rest, it's 5. And so aerobic training is going to increase that as well. So when we look at the cardiodynamics, when we look at cardiac output, what we're looking at is heart rate and stroke volume, and they're going to affect it. So the long piece of this, or how I'm tying it together, is we already said that cardiac output is directly proportional to blood pressure. But now we know that both heart rate and stroke volume affect our cardiac output, which means they also affect our blood pressure. That's the end goal where we're getting. So if my heart rate goes up and my stroke volume stays the same, then my cardiac output goes up and my blood pressure goes up. If I increase my stroke volume and my heart rate stays the same, well, that's going to raise my cardiac output, right? And then that will raise my blood pressure. So changes to heart rate and stroke volume directly affect cardiac output. Now you'll see shortly though that that's if, one goes up and one stays the same, or if they both go up, right? Well, what if one goes up and one goes down? Well, if that happens, then your cardiac output pretty much stays the same. And that is something that happens at rest when we change body position. And we're going to get into that shortly. So when we look at these factors, this lecture will focus on the factors on stroke volume, because we know that's a pretty important component of cardiac output. And cardiac output is one of the main players for blood pressure. In our next lecture, we will come back and talk about the factors that affect heart rate. So when we look at stroke volume, there are 3 factors that affect it, and you're going to star this one. The number one factor that affects your stroke volume is known as the EDV, or preload. So the EDV is the amount of blood in the heart, right, before it contracts. And just like a water balloon, as you fill a water balloon with more and more water, it stretches a little bit. So if we increase our EDV, we get a little bit of stretch in our myocardium. Now, the 2 guys that came up with this were Frank and Starling, and they came up with this principle. And they have a couple of them, but this is the one for the heart. And they said that what actually stretches your cardiac muscle is 2 things. It's something called venous return. That's literally the amount of blood coming back to the heart. So that makes sense, right? It'll stretch it. And then the actual EDV, which is the volume or the stretching. And the reason why stretching it gives you a higher stroke volume is because when you stretch your cardiac muscle, you get a stronger muscle contraction. Now, this is within limits. So if we think for a minute, taking you back to your A&P 1 days. So I'm going to try to draw this is going to be my thick muscle protein. Right, so that would be myosin. And then remember that there's actin. So I'm going to draw this way first. Let's see. I'm a little slow on the drawing. And remember that you would want the myosin to grab the actin and form those cross bridges. Well, what happens is cardiac muscle, just like skeletal muscle, when it's just its normal length, it's not optimal. If you were to stretch it a little bit, you're going to activate more cross bridges. And so think about it like this. They're almost overlapped. Okay. But if I were to have it, I'll draw it over here, more like this, then what happens is there's not as much overlap, so I'm able to pull it more. Think about it this way. Think about the size of the H zone is how much you can pull that muscle, how tight you can shrink that sarcomere. But when they have a little bit of stretch, you can pull it harder. So the idea is that the anatomy of the cardiac muscle is that their resting length is shorter than optimal. So if we stretch it, we activate more cross bridges. And it says within limits because you can actually stretch it out so that very few cross bridges can form, right? If it's too far apart, then the myosin can't grab the actin. And so what we see is that if we are able to stretch this a little bit, it contracts a lot harder, which means more blood leaves, and your stroke volume is going to increase. Now remember though that the cardiac muscle isn't super elastic. So if you are constantly stretching it, it can stretch out. And, if it does stretch out, then you have what's called congestive heart failure. And we'll look at that when we get back to the clinical applications. So we know that if we can stretch it just a little bit, it's going to give us a stronger contraction. And so the relationship is that my EDV which is also called my preload, right? Think about the water balloon. Like I said, the water is the fluid, the stretch, so is the blood. So we would say that my EDV is directly proportional to my stroke volume. So remember what that means is if my EDV were to go up, so would my stroke volume. And vice versa. If my EDV were to fall, my stroke volume would fall. And so when we look at this, there's two factors that affect EDV. And so one of them is called filling time. And filling time is literally based on your heart rate. That's the amount of time you have to fill up the balloon. That's the amount of time blood can enter the ventricle. So if you have a really fast heart rate, right, there's less time. But if you have a nice normal heart rate, there is more time. So we all have something called a max heart rate. And it's literally the highest heart rate that you can still have enough time to fill your ventricles. Now we calculate it. We take the number 220 and we subtract your age. And that's your theoretical max heart rate. So we'll do the simple math. If you're 20 years old, your max heart rate is 20 beats per minute. And what that means is that when you're exercising maximally, you can get up to 200 and you'll be okay. But we all have a max heart rate. Over that, it affects the fill time. So when we look at arrhythmias, we do worry if someone is in some sort of fibrillation or flutter and their heart rate is 260 beats per minute, because it's going to affect that filling time. It will lower their stroke volume. And if you lower your stroke volume, you lower your cardiac output and you lower your blood pressure. Now, venous return is the one that's a little more variable we'll talk about. And it's literally how much blood gets back to the heart. There are several factors that affect venous return. One is blood volume. Well, if your blood volume goes down, then your venous return goes down because you have less blood. That makes sense, right? We'll do skeletal muscle contractions. When muscles contract, they squeeze on blood vessels. So exercise increases venous return. Venous return is also dependent on cardiac output. The cardiac output, right? How much blood leaves your heart? If more blood leaves your heart, then more blood gets back. So they're going to increase it. Gravity and peripheral circulation are a little bit different. So let's go over to this and let's talk about venous return. And we know that venous return has a pretty much directly proportional relationship with EDV, which is directly proportional to stroke volume, right? You see the relationships here to blood pressure. So anything that increases venous return will then increase your EDV, which will increase your stroke volume and increase your cardiac output and increase your blood pressure. Make sense? And the opposite is true though, right? So if anything should drop our venous return, then every one of these values decreases, and that's probably not too desirable. So we already know factors that increase all of these, which is right, are anytime we have an increase in blood volume, right? So we have normal hydration. If you're dehydrated, it would lower it. If we have our cardiac output, and we know that exercise, that skeletal muscle contractions increase. Well, venous return is also dependent on your body position. So think about the effects of gravity on your blood vessels. And so if you were to lie supine, lie flat on your back, you're going to have the greatest venous return because you're lying down and gravity isn't impeding it. When you stand up, your blood has to work against gravity to get back to your heart. So when we are supine, we have the greatest venous return, which means we have the highest stroke volume. Now, in this case, though, because our stroke volume goes up in this situation, lying down, our heart rate actually falls because we don't really need to raise our cardiac output. We're just staying there. It's going to stay around 5. And so when you lie down, you have your lowest heart rate because you have your highest stroke volume. When you stand up, now gravity is in the way, right? It's decreasing your stroke volume. So your heart rate has to go up to maintain your cardiac output. So that's how body position affects it. And the other thing you saw was peripheral circulation. And one way to think about peripheral circulation is something called TPR, which stands for total peripheral resistance. And it's literally the resistance to blood flow. So it's the resistance that your blood is exposed to as it comes across, as it flows through your blood vessels. So anytime we can lower our resistance, we'll have our greatest venous return. So resistance could be due to atherosclerosis, right? You have deposits in your blood vessels. It could be due to some sort of constriction or tumor. So things that lower resistance are going to be things that keep your blood vessels nice and open. So anytime you have your blood vessels are vasodilated, you have a very low resistance and you have your greatest venous return. And so this is why there's medications out there that work like this way, right? With people with high blood pressure. When you have more resistance to flow, your heart will have to create more pressure. And we're going to get to that in just a minute because this whole resistance really has something to do with ESV. Now, contractility is just a stronger muscle contraction. So it's anything that makes the myocardium contract harder. So it's an increase in strength independent of EDV. You don't have to stretch to get the increased strength. In fact, what it does is it gets more calcium. So contractility are things that get more calcium inside the myocardium. Remember, calcium is critical for removing the TT complex and activating those cross bridges. So if you were to get more calcium in, you get a stronger contraction. So they're usually ions, drugs, or hormones. Now, positive inotropic is the word, inotropic action are things that increase calcium entrance. And so they're going to increase contractility. So if I increase my contractility, I directly increase my stroke volume, right? And then that will raise my cardiac output. So these are things that make the heart contract harder. Negative inotropic actions are drugs or hormones that block it. So they suppress it, they make it weaker. Well, you might be wondering, why would you do that? Well, sometimes if you're trying to give the heart a rest, then people might go on the negative ones. So what are some examples? These are the drugs that do it. Norepinephrine, epinephrine, T4, dopamine, and digitalis. So their mechanism is to increase calcium availability in the myocardium. A lot of times it doesn't let calcium leave the cell, so you get a stronger muscle contraction. Things with a negative, acetylcholine, beta blockers, you do not need to memorize their name. I just threw some you might recognize, or calcium channel blockers. So these are things that have a negative effect, which means that the heart won't contract as hard, which sometimes you just want to back off a little bit and let it rest more. The last factor is our end systolic volume, which is our afterload. And this is due on stretch. So just a quick picture I found. Preload is the blood coming in, right? And as the blood comes in, it fills the chamber and it stretches it to give a stronger contraction. Afterload is how much leaves. So afterload is a factor of resistance. If there's more resistance to flow, less blood can leave. Blood vessels are pipes. If you ever had a clogged toilet, right? You can't get the stuff out. So you have to get the plunger and generate some more force or pressure to force it out. It's kind of the same way when we look at our blood vessels. If we have a lot of resistance in our vessels, if we have a lot of that, we have high TPR, we have high total peripheral resistance, we have a higher afterload. If we have a higher afterload, blood can't get out of the heart. And so when that happens, our stroke volume is going to fall. So the higher the afterload, The longer the isovolumetric contraction, which means you have less time for ejection. So your ESV goes up. Remember, it was normally around 50 and your stroke volume was around 70. Well, if less blood is able to get out of the heart, then it's going to change, right? It could swap, right? Maybe you end up having 70 left over, which means you only got 50 out. So that's how the afterload works. So I like to kind of show it if we go back to the cardiac cycle. We're just going to focus on one phase of the cycle where we had this whole ventricular systole. So remember that ventricular systole, the ventricle is contracting. And there were two parts to this. Do you remember you had your isovolumetric contraction? And the purpose of that was to open the aortic valve. So let's keep it simple. Let's pretend I'm totally making up these numbers now. Let's say that the whole time for ventricular systole, let's pretend it's 4 seconds. Okay, that's all you got. Now, in a normal, healthy heart, you're going to pop open the aortic valve in 1 second. You have normal afterload. So you only have to use up 1 second of that, which means you have 3 seconds for the next phase. Remember, the next phase was the ventricular ejection. This is when the blood actually leaves. So now you have 3 seconds, so you have a nice stroke volume. Okay, let's take someone with a lot of afterload. So now we'll just draw it right up here. Okay, same setup, but now I have more afterload. Well, if there's more afterload, my blood will not leave at the same pressure. It's going to take more pressure to open the aortic valve because you're opening it against force, right? It doesn't open it, remember over here, it opened at 80. Maybe now it doesn't open until 110 because it's like the toilet. You have more stuff in your pipes. So you need to generate more pressure to force it out. So now this individual is spending 3 seconds just trying to generate pressure, which means now it only has 1 second to eject the blood. So less blood will leave. So that afterload directly affects how the heart is able to function, and it doesn't let the blood get out. You can't. There's too much pressure in your pipes. So again, your resistance is too high. Vasoconstriction, tumors, blockages, all of that will increase the afterload. So this is a summary picture that I think is kind of helpful, showing you the 3 main factors that affect stroke volume: the venous return, the contractility, and the afterload. And so I think it might be good to take a few minutes and just kind of read through these and make sure you understand how they affect the EDV, the stroke volume, the cardiac output, and the blood pressure. So this concludes our lecture.